So welcome everybody. Thank you for joining us at today's Improvement Forum. We're a bit light on numbers in the room today, which is to be expected really given how hot operationally it is out there at the minute, but hopefully a number of additional members of the team will be able to watch this back at a later point and join in and share later on. Can you take us through to the agenda for today, please, Carly? So usual format in terms of spotlighting some improvement work across the trust, and got real variation in what we're talking about today. So Jonathan here to talk about ankle replacement surgery and the great work there. Rachel joining us, thanks Rachel, to talk about same day emergency care and some collaborative work with patients there. And then Richard talking about video appointments. We'll talk about how to get in touch with the Academy and how we can support you bringing your ideas to life, a bit of an update on the training programme, and then just sharing and celebrating some good news stories from across the Trust. So shall we get going and straight into Jonathan talking about ankle replacements?
That's lovely, thank you very much. So let me just see if I can share my screen. Now, can you all see that pretty reasonably? Take a deafening silence as yes. So yes, you can replace total ankles. It's been going now for a while.
Jonathan, just to interrupt, apologies, but no, we can't see that.
Can anybody see my PowerPoint slides there? So I think you'll have to give me present. Oh wait, there we go. Running through it too quick. Good. You should be able to see this now.
Yes, we can. Thank you.
Lovely. Sorry about that. As always, it's linking iPads into the trust system. So yeah, you can replace ankles. People have been trying to do it now for the best part of 30, 40 years with minimal effectiveness to begin with. We're now on the 4th generation of ankle replacements. I personally have now been replacing ankles for about 4 years with the new Infinity ankle replacement. And they are gaining traction. More and more people are now considering ankle replacement as the gold standard. Just like you would with hip and knee replacements, you wouldn't consider a knee fusion or a hip fusion anymore as a standard of treatment of care. So yeah, the reasons why the Infinity ankle replacement is different to the other brands on the market is, as you can see, it's X-ray controlled, so you screen it intraoperatively with all these jigs to make sure you're putting the ankle replacement in where it's supposed to go. This is a little video off of the Right Medical, or now Stryker, website showing the surgical technique for those who are interested. The ankle replacement itself is a titanium alloy. It's got a plasma coating on it. It's uncemented, meaning that the bone grows onto the ankle replacement itself and bonds it together permanently. In between the two titanium components, you've got this ultra high molecular weight polyethylene shim that acts as the bearing surface. And the next change for the ankle replacements is that they're a fixed bearing. So that's a little bit about what a total ankle replacement is. I guess the next question I always get asked is why a total ankle replacement? Because we know that an ankle fusion, which is a very commonly done operation, is a good operation, and it's a lot cheaper. So the retort I have to that is this. You can see on your screens here 3 sagittal plane radiographs. The first over here shows the ankle arthritis that this patient has got. And again, the tibia has to move over the top of the talus in a anti-clockwise direction. The next patient has this, which is talar-navicular joint arthritis. Again, the talar-navicular joint moves in this anti-clockwise direction. And then lastly, you've got subtalar arthritis in this patient. And again, the moment of movement is all in the same plane. So if you've got a patient with just isolated ankle arthritis, then the data would suggest with the older generation ankle replacement, equivalence, meaning that an ankle fusion or an ankle replacement is just as good. The problem we have is we're seeing a lot of patients presenting to our department with all three joints that are arthritic. And if we fuse all three joints, they then can't walk. They effectively have a blood peg leg attached to their knee, and they don't like walking on this. So the only options we've got would be to fuse the joints that we can only fuse, being that of the talar-navicular joint and the subtalar joint, and then replace the ankle joint. That gives them some movement in their plane of travel. Now, what we've found is that when you replace the ankle joint first and ignore either the talar-navicular or the subtalar arthritic joints, is that those joints then stiffen up and settle down, so they don't then need those joints fusing. So instead of doing a three-joint fusion, you can do a single joint replacement, and the data is then supportive of this. So the next question is, what is a total ankle replacement clinic? And that's these motley crew. We have got, if I can introduce people, we've got Lorraine Sanderson, who's very experienced. She's our current arthroplasty nurse, along with Debbie Ferguson. My colleague, Matt Morris, most of you will know. In the middle there is Dave Sprott. He's a foot and ankle extended scope practitioner from the physio department, myself, and then Ashel Hara, who's our previous clinical fellow. And these people are all involved in the clinic at the same time. So instead of all these people individually dipping into the patient's care, ad hoc as needed, we decided to bring all the ankle replacements to a single clinic, so that we could get the expertise of everybody in the room at a single time frame. This has allowed us to unify our treatment algorithms in terms of who we're offering ankle replacements to, their post-operative rehab. It allows us to highlight any problem patients. It allows us to learn from each other's experiences. And the big thing that you can see just on the front here is the health questionnaires. This is broadly based on standard foot and ankle PROMS data, and we're using the MOX-FQ, the EQ5D5L, the visual analog score, and a few physio measurements so that we can get a real-time measurement of how our ankle replacement patients are doing. So that's lovely. But the question is why do we need all of this occurring in a single clinic at a single time frame? And these are the reasons why. So about 10-15 years ago now, the National Joint Registry started up, and the ankle replacements have been joined into this, and they've been collecting data on this now for the third year, I think it is. And this is monitoring implants, techniques, VT prophylaxis, the patient's weight, associated procedures, and it's going on to the National Joint Registry database. So it is publicly visible of who's replacing ankles, how many they're doing, and subsequently how many are being revised because of issues. Now you can see on the pie chart on the right, ankle replacement as a percentage of arthroplasty within Chesterfield Royal is less than 1%. The big ones being hip and knee primary replacements. And we're, as myself and Mr. Morris are putting in, we're putting in roughly about 32 replacements every 3 years. The national average over the last 3 years has been 13. So we're putting in more than most hospitals, but the big units in the country are striving to put in around 30 a year to keep the numbers up, to keep the quality up. So this is why we want to remain GIRF compliant, to ensure that what we're doing for the patients is of good quality, good value, and is done properly and well. These are the health questionnaires that we're using to try and prove what we're doing is right. Now, anecdotally, we're getting a lot of patients back that are very happy. They have their ankle replacement done. It's the best thing they've ever had done. And then we can monitor them every 5 years with x-rays, with clinic appointments to ensure that their health remains stable. Because what we don't know is how long these ankle replacements are going to last. The big data series now in the country are up to about 5 years, and we've got data just pushing over 7 years. So this will be a good piece of work to take nationally. So what could be improved as per the Royal Academy improvement? My vision would be is to automate some of the paperwork for this, so that ideally the patients can be sent automated messages to fill out their questionnaires online. We can then collect that and then review them remotely, either through a telephone call or a letter, reviewing their x-rays, reviewing their patient reported scores, and then bring them back into clinic at appropriate time points. We are collecting this data at the moment, and one of my medical students, Callum, has just finished data inputting it all. So we should have some real-time data over the next couple of months of how well we're doing with this. So that was a bit of a whistle stop around ankle replacements. I didn't want to eat into anybody else's time. Any questions from the audience? Or I guess, Maria, if there's questions at the end, I guess.
No, we can go now, Jonathan. Thank you for a brilliant presentation. It's great to see that. I was already expecting Anthony's hand to go up first. So what you're talking about, Jonathan, fits really nicely in terms of our ambitions around using digital health questionnaires. And Anthony particularly has been scoping that piece of work. So I'll let you come in, Anthony.
Hello, Mr. May. So it was just to ask, in terms of doing the health questionnaires, we had a meeting with Netcall yesterday to find an area to trial this with, to actually look at digitising it and sending it out through Patient Hub. So if you're interested, I think Amy Rowland's on this call as well. She's from IT and implementation. We can look at doing that for you and set that up onto Patient Hub, and you can be kind of our proof of concept service as well. Obviously, if you've already got it in place, that's fantastic.
No, not at all.
And what we can do, one of the things we're looking to do is to link in with that. So, you know, we've been using the patient-initiated follow-up quite extensively.
Yeah.
If we can link the health outcomes questionnaire into PFU, and it can auto-generate appointments for patients. So if they score something that you set the parameters within, it auto-generates an appointment with them, or sends them an auto letter saying, you're absolutely fine, you know, unless needed, you know, that you feel it's not okay, contact us. So that's some things that I think I'll email you after this if that's okay, and we can discuss those things. And my next question was going to be, you talked about some of the patient outcomes for the you know, like the one-stop shop, basically, of you've got a full MDT working in the clinic to give the best care to patients. Have any of your patients got comparative experiences of like hips or knees? Because I was just wondering if we could use some of those as a cohort of patients to show that doing some of those one-stop clinics I bet have better outcomes patients, they prefer them. Because like you said, anecdotally, we have all that data, but unless we've got something to compare it to. So if there's anything like that we can start pulling together, that'd be fantastic. And sorry, Maria, I'll stop talking now. That's me done.
Yes, in terms of comparing them, anecdotally, patients definitely prefer an ankle replacement to an ankle fusion in the early days. We just don't know how long that will last for. In terms of comparing ankle replacements to hip or knee replacements, anecdotally again, ankle arthritis is just as painful as both hip and knee arthritis, and we know that through Glazebrook et al.'s work from Canada. In the trust, we've noticed that ankle replacements are outperforming pain relief and functionality over knee replacements. They're probably not as good as a hip replacement yet, but that's not surprising considering how well hip replacements function and how long they last for. In terms of comparing the actual clinic outcomes themselves and whether we can improve PROMs and PREMs through just having a single stop MDT, I would be very happy to start collecting PREMs on the door of their patient's experience of the target clinic, total ankle replacement clinic.
Brilliant. Thank you.
that's what this forum is all about bringing pieces of work together and taking the piece of work to the next level. So Anthony, I'll leave it with you to get in touch with Jonathan. Sally, did you want to come in?
I just wanted to ask what age range we were doing the ankle replacements in comparison to, obviously, there's more traditional joint replacements.
Age does play a factor into it. Now, obviously, there's no absolute cutoff because every patient's individual. The data would suggest that most ankle replacements in the country are put into around 55, 56-year-olds, obviously with an age range to the top end of 90 and down. I think the youngest in the country is about 18, but you don't know how long this replacement is going to last, and your revision options afterwards are ever more increasing bone loss, bone stock issues, and complexity. So you need to be counselling your patient that this may not see them through to the end of their days, and they will need a replacement, a revision at some point. And the patients get on board with that. So, but we're not seeing the revision rates of the old ankle replacements with the Infinity, so they're not failing early.
Thank you for that.
Thank you, Jonathan. I think that's questions over, and we've got a plan to help move forwards, which is great. We were definitely looking for that first follower site in terms of the digital health questionnaire, so that fits really nicely. We will be in touch. Thank you very much for presenting today, Jonathan. Rachel, can I hand over to you to talk about the same-day emergency care experience-based design survey?
Yeah, brilliant. Thanks, Maria. Good afternoon, everybody. My name is Rachel Traveller. I'm the Assistant Service Manager for the acute care unit. So can I just go to the next slide, please? Thank you. So there's a little bit about what SDEC is there. So we have the medical SDEC area, which was relocated to Suite 4, which is the medical day case unit. This was part of the Trust's COVID response.
You've just gone on mute, Rachel. Hi, Rachel. I think you must be struggling with glitches.
Sorry, I'm back.
You're back.
I'm back. So SDEC was originally based on the clinical decisions unit, which was down on the EMU spine. But part of the COVID response, it was moved on to Suite 4, which is down in the medical day case unit. It was a quick change, which meant that we had to risk assess the area and also make sure it was okay for patients to be in. We were contacted by NHS Elect, who wanted to see if we wanted to take part in the experience-based design questionnaires. So we took up their offer. The questionnaire, can I just go to the next slide, please? Sorry. Thank you. So it just tells you a bit about what the experience-based design is there. The idea is that we speak to 50 patients and 10 members of staff to collate some information and find out what their experience is like in that area. Due to the inconsistency of staff in the area at the time, we only could speak to 50 patients. The idea is that we do it on an iPad, but we weren't able to do, we didn't have access to an iPad at the time. And also because of COVID, we didn't want lots of people touching the same thing. So we decided to do it on paper and upload the results at the end. Can I just go to the next slide, please, Carly? Thank you. So this is what one of the surveys looked like on the piece of paper. Now, ideally on an iPad, you can see the little smiley faces along the top there. So the patients would be asked how they felt before they arrived, and they could touch one of the smiley faces. So it's quite inclusive. So lots of different patients are able to use that if they, you know, that it's really versatile. So there were several options they could use. They could either just touch some of the smiley faces, they could touch some of the words along the bottom, or they could add their own words, and they could also put a little comment in the box just to say why they felt happy, neutral or sad. And then it'd go on to the next bit. So it'd ask them how they felt during the investigations, during the treatment, and then the next steps. So if you can just go to the next slide, please. Thank you. So these are some of the results we gathered due to the number of patients that were coming through. Like I say, we did it on paper. I went down every day, dropped off some surveys, and then brought the surveys back at the end of the day and uploaded the results onto the system. And the results we got were really, really good. As you can see here, we've got an overwhelmingly green positive results from the patients and how they felt about the area. We wanted to do this because obviously it was quickly moved into a new area. We weren't sure how patients felt, but after actually speaking and sitting down to them as some of the patients, not recorded on this survey, but they sort of said because it was a more of an outpatient area rather than going onto a ward, they felt it was a more appropriate area for the sorts of things they were coming in with. So they'd sit in a waiting area and then go into a chair rather than coming onto a ward area and seeing sort of like really acutely unwell patients. They just felt it was a better area for it. So you can see here the results. We've got a bit that we asked the patients about how they were feeling before they arrived, during the initial assessment and during the investigations. And you can see the way they felt. They felt happier throughout the treatment. So before they arrived, a lot of them were feeling worried about COVID. They were uncertain about why they were being sent in. They were worried about just the investigations that were going to be happening to them. But you can see here they've included their comments, and I mean they're overwhelmingly positive. Lovely staff, fabulous service, everything was explained well. Can you go to the next slide, please? Thank you. So the next questions we asked were about the treatment and care, and then the next steps. And you can see again, it's getting greener and greener as we're going along. So at the end of their journey to the next steps, you can see that 86% of the patients were happy with the overall treatment. The box on the right-hand side with the other comments, that's just the comments they were able to submit in addition to the actual survey questions. You just go to the next slide, please. Thank you. So the next steps. So we got a review back from NHS Elect, which was those pie charts you saw. Due to, like I say, due to the COVID response, we moved down to MDU, but the capacity isn't big enough for the amount of patients that are coming through. So since we've been down there, we've gone from seeing between 70 and 90 patients a week up to 150 patients plus. So we've recently been given Barnes water to move on to. So that'll be towards the end of the year, and that'll increase our capacity. And then once we're down there, we'll redo this survey and just see how the patients are feeling. And also hopefully, because we'll have consistent staffing, we'll be able to ask the staff as well. And then the idea is that the results are collated. So we can see that if there's staff thinking that the service is really, really good, but the patients aren't, we can just sort of like work out what's not working properly. We are doing this through ED, and we're doing it on frailty as well. So have you got any questions? I'm so sorry that I'm so nervous. And I don't even know why.
Don't be nervous, Rachel. Oh, I just love this. It's absolutely brilliant. It's really focused on listening to what our patients say, and it just gives you such a simple but fabulous view across the pathway, doesn't it, of a patient's journey starting to where they end up. It gives us the best assurance that we can possibly have about that we're doing the right things in terms of the patient experience. So I love it. You will know, Rachel, that we teach experience-based design on the CUSA programme, but I think this, for the first time, gives us a real opportunity to bring that to life, and we can use this example as a CRH specific example in our teaching going forwards, which I think people will really help everyone to kind of engage with it and understand how what sounds like a really complicated thing can actually be brought to life in such a simple way. So you've done a brilliant job. Thank you, Rachel.
Thank you, Maria. Yeah, we're really pleased with the response that we got from the patients. We weren't expecting such a fantastic response, and just to get it was really, it boosted morale on the unit, and it just shows that, they're doing a great job, and we're able to feed that back to the staff and just tell them what a good job they were doing as well.
Definitely, and I'm so pleased to hear that you're going to take this across frailty and ED, because there are such opportunities there, aren't there, to, like you said, it's for the staff to feel like they're making a difference along that patient pathway. So brilliant news.
Thank you.
Any questions for Rachel? No, thank you, Rachel. We'd love to hear about the further work that comes out, and like I said, if we can steal some of your slides, or you could perhaps come in and speak next time we're teaching on the CUSA programme about this, that would be fabulous. Thanks for coming.
Thank you.
Richard, I'm going to talk about video appointments and feedback from patients again.
Hi, yes. So for anybody that's been in the improvement forum before, we presented a video which was clinicians' experiences of using video appointments. And this is a follow-up to that, where we've interviewed some patients to talk about what they liked or what they got from a video appointment across different specialties. For those that have not attended before, just a brief overview really, that the trust prior to the COVID pandemic, like many other trusts, very rarely conduct video appointments with patients. And it's been something that's been delivered with quite a high degree of success over the course of the year, with, like a lot of things, rapid change. And we've noted that in particular services that they've been able to conduct many video appointments to the point where they are using video appointments in a way which has nothing to do with a response to COVID anymore, and it's just become part of business as usual, which is really positive. And we are getting positive feedback from clinicians in terms of the potential that video appointments can have, and not just for the obvious type of appointments, but we're using it in quite innovative ways, which is something that we've spoken about before. What's really, really positive is the feedback from patients is increasingly positive, in the sense that they are now reporting that they prefer it to telephone appointments, and they are reporting savings of money and time. They don't have to book childcare, and for many people it's more convenient. So clearly video appointments are not the answer to everything, and can't ever replace face-to-face appointments entirely, but this was just another opportunity to sort of emphasize the importance of video appointments and to describe to you some of the feedback that we're getting from patients. So this is a short video. I think there's 4 patients that were interviewed, if memory serves me right. Just bear in mind that one patient, well, they all recorded it themselves at home. One patient's kit wasn't great, so his video is a little bit jumpy, so just bear that in mind when you're listening to it. But yeah, any questions afterwards, please feel free to ask.
Hello, my name is Richard Gratton, and I work as part of the Royal Academy of Improvement at Chesterfield Royal Hospital. I'm currently the project lead for our video appointments project. The aim of this is to enable all of our clinicians to have the ability to conduct an outpatient appointment by video where it's both clinically appropriate and possible for the patient to do so. Prior to the COVID-19 pandemic, Chesterfield Royal Hospital was chosen to be one of 10 pilot sites in England for the use of a system called NHS Attend Anywhere. This allows appointments to be conducted by video, and it's a lot like having a video call by something like FaceTime or Skype. During the pandemic, we've been working hard to make this available for all of our clinicians, and to date, we've conducted over 5,000 appointments in this way across a wide range of our services. Our patients are giving us overwhelmingly positive feedback about their experiences. Here's what some of them have told us.
My name's Miriam. I brought my little boy to an online virtual appointment for paediatric physio. I was a little bit dubious at first about it being online. However, it didn't take long for us to develop a good rapport with the physio. She was absolutely brilliant. With it being in our own home, she was able to utilise his toys in the exercises and make it much more interesting and encourage him to do the exercises. It became more fun than the focus being on the exercise. So he wasn't self-conscious that he was having a physio appointment. He could relax and he enjoyed it, to be honest. We had about 3 or 4 online appointments with the same physio. And after the first one, we saw marked improvements in his balance and coordination. So what she was telling us to do was obviously working, which again gave us more confidence for the next time. We live about an hour away from Chesterfield Royal, so it saved us a lot of time and money on petrol. We didn't have to worry and have anxieties about parking. I've also got a younger child, so I didn't have to worry about childcare for him. And in the current climate, it was much nicer to have a consultation in our own home than have to wait in a waiting room full of people and add time to our day that way. We didn't have to take him out of school for the appointment because it was just right there and then in our home. And I didn't have to have time off work either. So I would definitely do an online consultation again. It was definitely an advantage for us at this moment in time.
I was diagnosed last February with a bit of throat cancer. I've been in and out of hospital. Once I'd finished my treatment, the chemotherapy and the radiation treatment and a bit of surgery, I was then home and I had to see a few consultants, and they offered me the chance to speak over video phone. I was in recovery and I really didn't want to leave the house at all, and joining loads of people inside a waiting room to do this appointment. So I took this up. I'd never used it before, so I wasn't quite sure, but it was really good. I had a stomach feeding tube fitted, and they had to see that I was able to turn it around and move it in and out and clean it. But this was all very doable on a video messaging service. So I did the video conference meeting with this consultant. Everything was fine with the feeding. I found I had a few more appointments come up. A nutritionist. They were wanting to get me back into eating. Obviously, I wasn't using my throat before. And it was excellent because they could demonstrate to me different training methods. It was really easy to do it online and follow their instructions, and I could show them that I was able to drink a certain amount in a certain time and eat a biscuit and that sort of thing. So I found them absolutely invaluable doing it online at home. It obviously saves you time and money, and it's better for the environment. It was all a very easy experience, and I'd highly recommend it to everyone.
Hi, my name's Kelly, and last year I attended some physio appointments online. I was initially quite sceptical about it, as traditionally I would have expected to have a face-to-face appointment. However, I was quite pleasantly surprised with the outcomes, and after almost every session I was noticing improvement. For me, the online appointments were really convenient because I could plan them around work, so I didn't have to have any time off. And not only that, because I could do them from my own home, it took away that added sort of stress of having to travel and park at the Royal. For me, that would have added an extra hour onto my day as well as my appointment. I would 100% have the online appointment again if I was offered it, and would definitely recommend for anyone else who's been offered it to have one.
About 18 years ago, I needed an operation to remove voice box due to cancer. The big operation makes a big difference. You have to find a new way of speaking. Since then, I've helped patients at Chesterfield Royal who are about to face the operation. Seeing someone who's come through the other side is very reassuring to both the patient but also their family members. I would normally meet the patient on the ward or in the clinic, but since March last year, that's not been possible. So I was invited by the speech and language therapist if I would meet a patient facing the operation. using a video conference, and I did that. I was very happy to accept the invitation to meet the patient and his wife to talk about my experiences. The platform used, I thought, was even easier than using Zoom or Teams. It was seamless. I had to do very little apart from click on the link. I know that the 20 or so minutes we spent was very helpful to the patient. I've been avoiding going to hospital where at all possible, and indeed mixing with people. I was very pleased to do it that way. I don't think I would have wanted to actually have a face-to-face meeting at that time. It's so much better than a telephone call. I would have no hesitation in using a video call to meet a clinician myself.
So as you've just seen and heard, our patients have given us really positive feedback about video appointments. 97% have told us that they would have another appointment in this way. 78% have saved up to 2 hours compared with having a face-to-face appointment, and 75% of patients have saved up to £15 simply by not having to come to hospital. In the coming months, we're aiming for all of our services to be able to offer video appointments so that more patients can benefit from having some of their care provided in this way. Thank you for watching. If you want any more information about this project, you can visit our Trust web pages, or you can contact me at the Royal Academy of Improvement. Okay, so hopefully that was a useful video to watch in terms of what some of our patients are telling us. It's quite interesting to see how positive the feedback that we're getting from patients is about video appointments. We've received very, very little negative comments. The only things that have hindered patients and clinicians to some extent is things that are outside of their control in terms of their network connection, but they are relatively rarely reported from a patient point of view. So really the purpose of this presentation today is just to re-emphasize to everyone who is in a position to offer virtual appointments, full stop, is that patients really are getting a lot from being offered a video appointment. So in all our outpatient areas, we're trying to enable clinicians to be in a position to do that whenever it's possible. So it's just to re-emphasize the fact that from a patient perspective, they are asking for us to provide video appointments where it's appropriate. I don't know if anybody's got any questions.
Thank you, Richard. Jonathan, did you want to come in?
Hi, yeah, that was a brilliant presentation. Really sort of opened my eyes to what the patients think of video conferences. A couple of questions. Firstly was, how did you select who to screen for your feedback videos? Or how did you screen them? Did they offer an opinion, or did you send out random information?
To be honest, Jonathan, it was slightly difficult to get patients to volunteer, in the sense that it's difficult to find patients, in the sense that although we're doing thousands, it's always a bit of a challenge to contact them directly and then potentially you influence them in a coercive way. So we asked clinicians across the majority of our services if they had a particular patient in mind who had been positive or critical about video appointments, or if they could ask at a further video appointment if they'd be prepared to be involved. So we tried to be as uncoercive as possible in terms of asking patients to become involved in this. The patients that stepped forward did so because I think that they had positive things to say. I suppose if I'm being honest, it'd be nice to hear some of the criticisms that we've had, although these have been so minimal that I'm not surprised that what the patients were talking about here was so positive.
And if I may follow up with a second question, if that's all right, if I'm not eating up everybody's time. one of the things that makes me nervous with video consultations is that I miss something that if they were sat in a room with me, I wouldn't have otherwise missed or may have. Is there a medical legal aspect of video consultations that needs addressing in terms of ensuring the quality?
Again, I think that's a slightly difficult question to answer, Jonathan, because video appointments are so much in their infancy within public healthcare, at least. I think that it's a learning curve that that's going on. Although questions around medico-legal issues are starting to be voiced and addressed. I think the important thing from our point of view, and I don't know if this entirely answers your question, is the majority of video appointments that we're seeing happen are follow-ups rather than new appointments. So whilst new appointments could take place by video, I think the fact that a lot of these are happening by follow-up means that the patient has already been seen, they've had an initial assessment and initial tests, etc. So that by the time we get to the follow-up, so much is known about the patient and their potential diagnosis or health problem that the video appointment is then seen as being a bit safer, if you like. I suppose the other thing to say is if during a video appointment or a telephone appointment, and bearing in mind at the minute we're doing far more telephone appointments than video, where you're unable to see the patient at all, that clearly if there were concerns, then you could schedule a face-to-face appointment after that. What we're not trying to do in encouraging video appointments is for clinicians to feel like they're under pressure to offer a virtual appointment if they're not sure whether it's appropriate. I don't know if that helps.
No, massively. That's my take on it all, is listen to the patient, and if they ask you to come in and see you, do so. Don't see it as the only option is to keep them on a video appointment because they're on a follow-up. But no, that was brilliant. Thank you.
No problem.
Thanks, Jonathan. Thank you, Richard. Brilliant piece of work. If any of you haven't already seen, that's our second video. The first video was our clinicians speaking about their experience, which is equally brilliant, and we definitely wanted to do the follow-up, so it's brilliant to see that. I think in terms of patient choice, that is really important to us, and we did a Derbyshire dialogue session with the Derbyshire public not too long ago, talking about the various improvement interventions in outpatients, and we definitely heard from the public that they wanted choice about the format of their appointment, so that's absolutely what we're setting as our ambition for the future in terms of patients having that choice. But you can definitely hear patients talking about the advantages they see in not having to attend if it's not necessary. Richard, we're doing some work, aren't we, around more innovative ways of using it? Just talk about some of that and how we can use new ways for the future.
Yeah, sure, no problem. So I think when people traditionally think about a video appointment, they would think that the vast majority happen where the nature of that appointment, if you like, is more around talking to the patient and just having a conversation. So my background with talking therapists, for example, lends itself very well to video appointments because it is the majority of it is a talking, it's just a conversation, if you like. But actually, we've seen lots of relatively innovative work. Speech and language therapy is a good example where clinicians during the pandemic were unable to go into people's homes, for example, and watch things like swallowing technique. And you saw a little bit of that in the example on the video, where via video, the swallowing technique can be assessed very easily in not necessarily all, but a number of patients by video. So say those patients coming in. CAMS are another good example. So child and adolescent mental health services. We've got a lot of we've got some clinicians doing mindfulness and yoga relaxation type techniques, which can readily be done by video in terms of a technique being taught. And that's similar to what's happening in physiotherapy services. And some of the new things that are happening with NHS Attend Anywhere, which is our current platform that we use, it's not at the minute able to facilitate group sessions, but one of the changes to the platform that's come in over the course of this summer if NHS E&I are correct, is that the platform will be able to support group consultations of up to 30 people. And we've already had lots of interest in the trust where we have been running group sessions face to face, but they may well be able to take place via video, which would be, again, hugely advantageous to patients.
Brilliant, thanks, Richard. And I know therapy services are one of the ones looking to explore that. And we've been struggling to capture the data around therapies, but we've got some latest data about how therapies are using remote appointments in kind of the broadest sense across all of their services. So it'd be good to schedule them to come to a future meeting and talk. But thank you for leading that piece of work, Richard. It was a brilliant piece of work, and it's great to hear the patient voice front and centre of our work. Shall we move forwards then? So Stacey's not with us today to talk about bringing improvement ideas to life, but we would absolutely love to hear from you if you do have an idea, and we can support you with your improvement journey. So get in touch if you've got an improvement piece of work that you want to progress. One of the things Stacey's been really focused on over the last month is more of the engagement session work with teams. So she's done a piece of kind of an ideas generating facilitated session with the team in the eye centre, and then a similar one with the team in pharmacy. And as part of those has come up with a number of quick win things that we've been able to facilitate just happening, and then some longer term improvement pieces of work. So that's an offer that we can support you with if you've got a team that you'd like to do an engagement session with. Next slide, please, Carly. So we've got the new Royal Academy of Improvement newsletter as well, so we would love to hear from you if you've got a piece of improvement work that you would like to showcase within that. They don't have to be big things, the small things really matter and add up, so get in touch with us if you've got a piece of improvement work to focus. We'd love to hear from you. Just a little bit about our improvement training programme and the offer that we've got. We have an introduction to improvement, which we've been constantly changing and adapting. This is an offer for anyone across the trust. It takes you through how you would build your improvement aim, your driver diagram, who you need to get involved in your project, and how you design your measures, and then take forwards the planning of your improvement idea. Really is for anyone. We've got sessions booked going forward, so please get in touch if you would like to join us on one of those sessions. I'm just looking, Victoria, actually the dates for that are quite far out. Have we got some dates sooner than that though, or are they booked up?
We had Mondays, which was the July session, so that one we had nearly full house, but then the next session we've got is September, and we're full, so yeah.
Oh. Okay, we'll get in touch, and if we need to, we can always have a think about putting additional sessions on if we get a waiting list for that. So thanks, Carly. Next slide, please. So we've also reintroduced our Quality Service and Improvement Redesign QSA programme back into the trust. So this is now running as a 6-day programme, slightly in different way than we ran it pre-COVID. We've taken the learning. The dates are scheduled now over a couple of week periods, and get in touch if you're interested in that programme as well, and we can schedule in, and we can put you in contact with someone who's been through the programme as well, so you can have a chat about whether it's right for you and what the programme consists of. Anyone in the team can talk you through that, or we can put you in touch with someone across the wider trust. Next slide, please, Victoria. So just a couple of snippets really of sharing and celebrating our success. We share these here, and they go into the monthly report that the hospital leadership team receive as well. So we try and be much better about sharing and celebrating success. So Ashover Award have been focused on falls with a range of different tactics, from mobility charts for behind patients' bed space, which was an idea shared from the surgery team, having a timeline so they can see when peaks in falls occur, and staff can be really aware of when to focus. And they're also going back to their Baywatch trial, looking at reducing risk with cohorting patients into bays. Robinson Ward have done brilliantly, achieved a silver on their safe and secure handling of medicines audit. Next slide, please, Carly. There's a couple of bits here about our carers liaison support service, which we always recognised was brilliant, but they've now been recognised externally. So they've been shortlisted as a finalist in the Commitment to Carers category at the Royal College of Nursing Awards. And the team were also sharing, celebrating Carers Week, and the Carers Information Ward Boards. There was a mini competition about where had the best Carers Information Ward Boards across the trust, which I believe Robinson won that one too. The EMU and SSU team have designed a new positive thoughts board, which is just really lovely if you go and have a look at that. Next slide, please. You'll know that we launched our ESR system, our HR system, back in April, but the self-service functionality that we've been waiting for a really long time is now live. So you can go in to access your personal information, look at payslips, etc., by either going into the website or downloading the ESR app. Our fabulous maternity team has been re-accredited as baby friendly, which is a really good set of standards designed to make sure patients are given the best opportunity to build close, loving relationships right from birth. Next slide, please, Carly. Our clinical engineering team, so often kind of undersold in the fabulous work they do behind the scenes. They've been fabulous during COVID at supporting us, but they've been shortlisted, and I'm going ahead of myself in saying won best use of technology category. So they've the team have presented here previously about the work that they've done with the registering and tracing of medical equipment. So it's fabulous that that's now been recognised with the shortlist in the HSJ. And on NHS Sustainability Day, we launched our green plan as a trust. So the action we're going to take towards the national ambition of the world's first carbon neutral health system. Next slide, please, Carly. And then finally, we celebrated 4th birthday of the NGS Macmillan Information and Support Centre. You can't read the detail on the poster, but it's definitely worth having a look at this because it celebrates, highlights some of the huge success that the team have had again over the last about 12 months, despite the challenges that were presented by being an information and support centre during COVID, and some of the fabulous work they did to take their services online. That was all of the slides, I believe. So we do have a couple of minutes if there are any pieces of improvement work or any topics that people wanted to raise that we haven't talked about today. Got no hands up, so we will finish there. Thank you so much for joining us today. For any team members who weren't able to join us, please let them know that this will be available online for them to view offline, and we hope to see you next month. Thank you to Rachel, to Jonathan and to Richard for sharing today. We'll see you next month. Thanks, everyone.